Good day, ladies and gentlemen, dear friends. My name is Vasily Rakhovi. I am the hand transplant patient from Innsbruck, Austria, and the founder of the Voice of ECR Patients. Welcome to the interview. Today, our guest is Professor Christina Kaufman, Scientific Director of the University of Louisville VCA program and the current President of the American Society for Reconstructive Transplantation. Good day, Professor Kaufman. Nice to see you.
Thank you for inviting me. I'm looking forward to this.
Thank you. Professor Kaufman, you work in a very special place where the first unilateral hand transplantation was successfully performed in January 1999. If you don't mind, could we start our talk with the history?
Sure.
Uh, could you tell our viewers, please, why and how did the surgical team of Louisville Jewish Hospital come up with an idea of launching the hand transplant program? And perhaps you could name us a few key figures behind that decision.
Okay. So it is an interesting story. Actually, the initial idea of the hand transplant program was Hank Wagner, who was the president of Jewish Hospital at the time.
Mhm.
And he recognized that with the Kleinert Coutts and Associates hand surgery team, which was really with Dr. Coutts and Dr. Kleinert, really one of the world leaders in hand surgery. And he wanted to make a splash.
Mhm.
And so he said to them, come up with something really novel. He says, what about hand transplant?
Mhm.
And so Warren Breidenbach took the lead on that. And he did a great job. He went all over the world. That's the first time I actually met him,
Mhm.
is when he came to Philadelphia and talked to Dr. Ildstad in our group about the immunology of hand transplantation. And so that took about 3 years, and the team screened over 800 people who were interested in a hand transplant and narrowed it down to one, Mr. Matt Scott. And in retrospect, it was a great decision because 27 years later, he is still doing great.
Mhm. Yes. Professor Kaufman, can it be said that the success of Louisville hand transplant program served as an example or some kind of inspiration for other transplant centers around the world? And of course, you have just talked about Mr. Matthew Scott. Did his life, his success 27 years after the surgery, also contribute to that success and development of other hand transplant programs?
Sure. I mean, it makes sense because, I think there is a need. Prosthetics are wonderful, they're getting better all the time, but it's still not the same.
Mhm.
Um, so some people they're fine, it doesn't matter. Some people it does. And so for those people that really want to really restore themselves, a hand transplant is a good option. Um, so I think it was, as more programs got involved, and even in our program, as we did more patients, unfortunately, the result is not as good as Matt in everyone.
Mhm.
And we learned a lot, and other programs learned a lot about what makes a good BCA candidate. What are the things that a hand transplant can restore, and what are the things that it can't fix. We learned that in order to be a really good hand transplant recipient, you need to be resilient. You need to be a not you need to be happy and be able to handle whatever comes. Some of it's going to be good, some of it's not going to be good. And the people that do well with a hand or any kind of VCA transplant, or any transplant for that matter, are the ones that just, keep looking forward, do the best they can, because that's all anyone can do. But I think we learned that it's really important not to raise anyone's expectations. If anything, you know, keep it very low key. Focus on what can go wrong so that people can make an informed decision about whether or not they can take this on. It's not trivial. It is a life-changing, you know, it's almost like having a job. You know, you have to take care of the transplant. I'm telling you, and you're an expert in this, so I apologize for that. So I think that's what other centers and our own center learned. You know, we did a couple of transplants after that that in retrospect weren't a good idea. But in some respects, you can only learn by trying.
Yeah.
And every time you try, you're not going to succeed. But you know, we're now almost 30 years later. I think we've learned a great deal. Obviously, there's still things we need to learn, but we know a lot about almost as much what not to do as we do what to
Hmm.
do. So,
Hmm. Professor Kaufman, and I think it would be interesting for our viewers to know how many hand transplantation have you and your colleagues performed since 1999, and were all those surgeries unilateral hand transplantation, or there were also double hand transplantation among them. And of course, it would be interesting to know how does it look like today. Is the program still active or not?
okay. So the first thing, I didn't do any surgeries. I'm an immunologist, so
Hmm.
I can't take credit for any of that work. But um, there were 10 hand transplants done at the University of Louisville, the first with Matt Scott. Most of them were unilateral transplants, but we did do, I think, three double hand transplants. So we did both. You know, there is you know, again, everyone's different. For some people, a bilateral transplant works best. For others, a unilateral. And both, you know, sometimes we were criticized that you don't need to do unilateral. They have one good hand, it doesn't matter. Well, you know, that's easy to say. Every person who has said that to me has two hands. So I don't think that they can make that decision for other people.
Hmm.
Um, so yeah, we did 10. We did have failures, I mentioned. So of the 10 that were done, you know, Mr. Scott, Mr. Fisher, Mr. Rickelman have done really well. Miss Acker has done well. Jerry Fisher, you know, but you know, we lost patients. Our fourth hand transplant recipient,
Hmm.
he lost his hand 9 months after the transplant, and that was a significant blow to our. Um, and but we learned that we were doing some things with the immunosuppression we shouldn't have been doing. We learned, I think, that in our hands, a regimen that includes sirolimus, tacrolimus, and prednisone, you know, early on, try to taper it off. And then later, if you need it, you need it. But, you know, relying on the tac sirolimus kind of regimen. I think that's important, and it's something, you know, that we need to look at because I think also that that regimen is somewhat protective of chronic rejection because we have far less than has been found in some other programs. Not that we haven't had some chronic rejection, because we have, but it's been less on that regimen. And again, we've got patients now that are decades out. All five of our patients are now more than 10 years
Hmm.
post-transplanted. And chronic rejection isn't an issue on their regimen. So I think that's important for other programs to learn from.
And is the program still active today, or
Un-
how?
Unfortunately, it is not.
Hmm.
You know, I mentioned when we started that the initial idea for the hand transplant program was a seeing president of the hospital.
Hmm.
Unfortunately, the current president of the hospital is not as forward thinking. And honestly, because the program wasn't making any money, he shut it down.
Hmm.
So the U of L program actually is no longer active.
Professor Kaufman, I think you are a very important member of the team. Therefore, I formulated my questions like I said, as you and your colleagues. Yeah, I mean,
Yeah, yeah. No, I just want to, I'm very careful that
yeah, yeah,
to give
okay,
credit where credit is due, and the surgery is not
yeah.
me.
But it is only one part of the procedure.
Yes, yes,
Yeah.
it is.
Yeah.
You bring up an excellent point. There is no one person that does a hand transplant. It's a huge team,
Mhm.
and that team includes follow-ups, that goes for decades. So it's a big effort, but I think it's an important one, and fortunately, economic realities are just something we have to deal with. And while the U of L program has closed down, I'm happy to see that there are many programs in the United States that are active and moving forward and
Mhm.
doing new things. So I'm still excited. I'm really lucky to be part of the American Society of Reconstructive Transplantation. We're working on our meeting for this November. And by the way, we want you there. Um, and it's going to be an exciting program. We're just getting it started now, but it's going to be actually focused on the patient perspective for this meeting. So I'm pretty excited about that.
Where does it take place, the meeting?
In Chicago, it'll
Okay.
be in Chicago, November 19th and 20th. Yeah.
Mhm. Thank you. Professor Kaufman, and were you and your colleagues focused only on the hands, or were the program expanded to other type of external organ transplantations? I mean, face, larynx, or it was only about the hands?
Yes, so our program was focused only on the upper
Mhm.
extremity. Again, that hand surgery is a big strength at the University of Louisville with the Kleiner Coots Hand Care Center. So that's our huge strength. Not that we don't have good plastic surgeons there, but they weren't interested in face transplantation.
Mhm.
Um, but as you know, obviously there are many types of transplantation, and we certainly will cover all of those at the ASRT meeting.
Mhm.
Um, and there's also some interest in lower limb transplantation, which is something I don't think many people have focused on.
Mhm.
So we're planning to have a session just to readdress that subject. Is there a need? There are patients that would like it again. We're focusing on the patient perspective, and is that a direction that a program might want to pursue? So um, again, as you know, this is a discussion. It's changing. New things happen. So it's fun. It's a great field.
Yeah, you're right. Professor Kahn, you lead the group of Louisville hand transplant patients. Yes, and we have already started talking about patients, but perhaps you could tell us a little bit more about your patients. Who are there? And what do they all have in common?
There is no one size fits all for hand transplant.
Mhm.
Every single one, and that is how I think the field of VCA differs a little bit from solid organ transplantation, because you don't have to be so careful with a heart or a kidney. It has to match immunologically and be in good condition. But other than that, um, but all of of the 10 patients who received the hand transplant, the one thing that was in common, especially those that were very successful, was being 100% involved in their care, and being the captain of the ship. Really, it's their hand transplant. Um, you know, being very proactive, being extremely compliant. These are the things that characterized our hand transplant patients. Other than that, they were all extremely different.
Mhm.
Um, we had, our second patient is he has a business installing gutters on houses, and he again, he's more than, um, let's see, he was 2001, I believe. So, I mean, he's nearly over 25 years post-transplant as
Mm-hmm.
well. He's had some challenges recently, but he's doing well, still working. Mr. Scott is doing well, still working. Um, our Mr. Rickelman, who he again, his hand looks terrific. He's actually having a little bit of issue with Raynaud's. He's in a cold climate now, and he's having some issues with that. Um, but as part of when the U of L program shut down, then all of our patients are migrating to other centers. So um, happily, there are several centers in the U.S., and so
Mm-hmm.
they're going to them to receive their care. So um, um, I think Mr. Rickelman is going to be seen at Mayo Clinic to deal with those issues. But
Mm-hmm.
again, overall, he's doing very well. He's doing very well. And that's something, that as the field grows, that this is something that's going to happen. So one of the initiatives of the ASRT is to come up with a list of sites that do VCA transplants and also sites that will accept referrals of follow-up of
Mm-hmm.
patients from other centers. Because not every center does, because again, do you have the resources? You have to make your administration happy.
Mm-hmm.
So, some say yes, many say, appropriately the same as any other transplant patient. If a kidney transplant wants to be followed at another center, the physicians look at them and on a case by case basis, they say, yes, we can take you on or make that decision. So I think this is a sign that the field is growing up a little bit,
Mm-hmm.
um, you know, moving from a totally research, you know, can we do this?
Mm-hmm.
I think we're at the point now that yes, we can.
Mm-hmm.
Not that there isn't room for improvement, and we need to continue research, but now we're dealing with real life issues. People move, things change,
Yeah.
um, and and it's just not if it's going to work. It's how am I going to live with this the rest of my life, which
Yeah.
is cool.
Yeah, you are right. Professor Kaufman, you are the author and co-author of many important studies on chronic rejections and blood vessel problems after the hand transplantation. Could you explain to our viewers, please, what chronic rejection is and how is it different from acute rejection? And it would be very interesting to know which tissues of the hand, which parts of the hands maybe, are mostly affected by the rejections.
I think the primary issue with chronic rejection is that um, I think one of the first targets is actually the blood vessels.
Mm-hmm.
And when you reduce the flow, then obviously the tissues aren't working as well.
Mm-hmm.
So there's many ways that chronic rejection can be manifested.
Mm-hmm.
The skin becomes not soft, it becomes coarse and stiff. Um, the adnexal structures. So one of the targets is the fingernails.
Uh-huh.
Um, you know, Patients can lose their fingernails.
Mm-hmm.
Um, you know, the hair is a target of chronic rejection, and this is true for hand or face. That the if you have any hair in the skin, you lose that, and it becomes either thick or very thin. Um, and so the I think an issue that we need to deal with chronic rejection is it's much easier to prevent than cure.
Mm-hmm.
Once those chronic changes are there, they're there. And certainly you can take steps to prevent further progression, but
Mm-hmm.
I don't think there's a way that once chronic rejection is the signs are there. Like once the fingernails are lost, they're lost. They don't grow back.
Mm-hmm.
So, um, and again, one of our patients did well without the fingernails. He was more sensitive, um, and he did well. Unfortunately, he died of other reasons, and so that's another issue that patients considering a VCA transplant have to consider. Immunosuppression is immunosuppression. That's good for your transplant. It's bad for things like cancer, infections, so that's the balancing board. So one of our third patient did pass away from squamous cell carcinoma.
Yeah.
Now, he was immunosuppressed. That absolutely contributed to his cancer diagnosis. But he also spent every winter in Phoenix, didn't use sunscreen. Um, you know, People that are not on immunosuppression get cancer too.
Yeah.
So, but again, does taking immunosuppression raise that risk? Yes, it does,
Yeah.
no doubt.
Mm-hmm.
So, so these are, and so as you know, this is the difficult job of educating a patient who wants a VCA transplant. So this isn't, you make an appointment on Tuesday, next Thursday at 3 o'clock, you can get your VCA transplant. No, this is months, if not years, to make this decision. So.
Yeah. Yeah, Professor Kaufman, and what are vascular complications and why they are dangerous to the hands? What problems can they cause? Could you please also? Uh,
Yeah. So literally, so our fourth patient that lost his hand at 9 months, he was really an unusual case because he was doing great. Although after the fact, we realized he was taking some medications he shouldn't have been taking. He
mhm,
was using the hand more than he should have been using it. So that contributed. But he had a no skin rejection. The hand was fine, but he actually lost blood flow to the hand. Um, when we By the time he came to Louisville and the hand had to be amputated, the vessels were completely sclerosed. There was no blood flow going through,
mhm,
and it happened very fast. And thankfully, that's the only time it happened so fast that there weren't even any skin changes before the hand was lost due to lack of blood. You have to have blood
mhm,
flow to the hand.
mhm,
Um, in chronic rejection, there can be something like in the middle of that, where
mhm.
there is thickening of the arteries, reduced blood flow.
Yeah.
And I
Mhm,
think that's why you get the loss of the fingernails because there's blood flow to the hand, but it's not quite enough. And, the tissues that are not well vascularized, like the fingernails, and the hair follicles are some of the first things to go.
mhm,
Um, so, so that for me, chronic rejection is that, not quite enough blood chronically literally results in chronic rejection.
mhm. Professor Kaufman, you personally know a lot of hand transplant patients, and could you tell us, please, from your experience, how do the age change the transplanted hands? I mean, do they all age along with patient or not? I mean,
They,
hand function,
so,
appearance, yeah.
so we have an interesting case. I don't know if I ever told you this, but Mr. Scott's donor
Uh-huh.
was 57 at
Uh-huh.
the time of transplant. And Mr. Scott is now 27 years out.
Mm-hmm.
So his hand is well over 80 years old. And
Mm-hmm.
it does look like it looks older than Matt.
Mm-hmm.
Um, and it's doing well, but and I know this very well. I'm not 20 anymore, and my skin doesn't look like a 20-year-old,
Mm-hmm.
and it's the same thing. So, it in our very limited number of patients, that I've seen, yes, it appears that the hand once transplanted ages as it would normally. If and
Mm-hmm.
our Mrs. Acker, her donor, she was older when she got her transplant. She was actually 69, and her donor happened to be from a young woman, and her hands still look like a young woman's. So
Mm-hmm. Yeah, very
yeah,
interesting.
so
Yeah. Professor Kaufman, many of your colleagues believe that VCA should belong to the standard of care. And in your view, is it possible to overcome insurance reluctance to cover the whole procedure, pharmaceutical companies' limitations in development of new drugs suitable for such a small group of patients like VCA patients? Does it mean, or will it mean that VCA remains a rare or inaccessible surgery for the most of the patients? How do you see that?
So I know that today in the United States, there are companies that will cover hand transplant.
Mm-hmm.
Um, there are situations where hand transplant is covered. In fact, one of our patients was actually part of a workers' compensation. He worked at an auto factory and he lost his hand due to an injury on the job.
Mm-hmm.
So his transplant was completely covered, and his post-transplant care was completely covered. I've talked to Medicare, which is it's mostly for older patients, but I talked to them and, it's difficult for them to say, yes, we approve it.
Mm-hmm.
That's very difficult for them to say, but what they will say is, again, on a case-by-case basis, we
Mm-hmm.
certainly will consider it.
Mm-hmm.
And so I think, especially, and there's something that we can get in the United States called a local coverage determination. So within your region, you have one group of administrators that say yes or no to procedures. And again, this isn't just for hand transplant or BCA, it's for all procedures. This is how it works.
Yes.
Um, so, and I know that we've had meetings where we've invited representatives of the insurance companies, and they said, "Yeah, we will cover." Th- this isn't something we would say no to because it just doesn't happen very often, and VCA never will happen very often because it takes so that's just the nature of these kind of transplants. Most people don't need a hand transplant. For those that do, this is the answer. Most people don't need a face transplant, but for those that do, this is the answer. But it's always going to be rare, which is good. Um, and so they said, why doesn't an insurance company want to cover something? Because they don't want to lose a lot of money.
Mm-hmm.
And this is the feeling that I've gotten from conversations is this is never going to be very expensive to us because it's just never going to be that many people. So they don't see a huge roadblock to insurance.
Mm-hmm. Mm-hmm.
So
Yeah. Thank you. Yeah. Professor Kaufman, you are the president of the American Society for Reconstructive Transplantation. First of all, I would like to ask you, are uh, VCA and reconstructive transplantations the same things? And what are your key uh, missions, plans in this position? Do VCA belong to them?
uh, the primary mission of the ASRT is to uh, disseminate knowledge about VCA,
Mm-hmm.
to um, be a resource to patients, to be a resource to transplant physicians and hand surgeons and reconstructive surgeons that this is an option.
Mm-hmm.
Um, I think, I actually have just reached out to reconstructive surgeons and said, is this something you would consider? And many of them just are like, no, 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 um, but, like everything, you need to try something and think about something before you form an opinion.
Mm-hmm.
And I think in the case of many reconstructive surgeons, they form an opinion before really understanding, um, you know. And it's not, there is also a thought maybe that we're competing with prosthetics. but we're not competing with
Mm-hmm.
prosthetics, for a person, that is it has to be the individual that decides, is a prosthetic best for me or is a transplant best for me? And many, it's a criteria for our program. This doesn't work for face transplants as much or other types of VCA, but for our program, you have to have tried a prosthetic and
Mm-hmm.
failed, you know.
Mm-hmm.
So if you can use a prosthetic, we don't think that you should get a VCA if you're happy with it, if you're able to accomplish everything in your life that you want to accomplish, if you feel whole, you don't need a VCA. So, we almost tried, not almost, we try to talk people out of VCA.
Mm-hmm.
So this is so I think, that's the goal of ASRT, to be a resource, to be educators, to be inclusive, but also to promote the possibility of this, and not have it. There are those that say, it's not enough patients. It's just not worth the effort. University of Louisville made that decision. Um, it's never going to make. It's not a money maker. It's not a money maker. Um, but I think, like any other kind of tertiary high end type of um, endeavor in healthcare. You know, it's these kind of areas that you learn things that can be translated to other areas of healthcare.
Mm-hmm.
So, what would our healthcare system be like if we only focused on people with colds and
Yeah.
said,
Yeah.
you know, if you have something more serious, we don't want to deal with it.
Mm-hmm.
Um, but when you deal with the odd things, the hard things, you learn things that help you deal with the colds and the simple things. You get new treatments, new drugs. So I think that's an important part of ASRT, to protect this, unusual um, but life-changing procedure for some people.
Mm-hmm. Professor Kaufman, on what programs, projects do you work in your position now? Could you tell us, please, about that too?
So what we're focused on now is the meeting in November.
Mm-hmm.
And, so we literally meet as a board once a month. And, there was, um, we had to scramble a bit because we were assuming that the meeting would be in Louisville, and it wasn't. That's not going to be possible. So we're super excited. Dr. Rolf Barth, who's been active in the VCA community, he offered to let us do it at the University of Chicago. And we're really excited. It's going to be in the Rubenstein Center, which is a beautiful facility.
Mm-hmm.
And there's all kind of venues. There's lots of housing at the University of Chicago, or if you want to go downtown, you could stay. And the ASRT historically always met in Chicago.
Mm-hmm.
And then recently, we've been going to various centers. So I think everyone's pleased to be back in Chicago, and it's such a beautiful facility, and it's central. It's easy for people to get to that are on the East Coast, West Coast. That's what we're focusing on. The NACOSs are always involved in the ASRT meetings, and so they asked if we could focus on that a little bit, and so we're going to have a session focused on, you know, what is it? What are the indications? What are the, just to discuss it again.
Mm-hmm.
That's an area, lower limb transplantation within the field of VCA. Many people say, don't do that. We don't need it. Prosthetics are good enough. And
Mm-hmm.
again, for most people, prosthetics are good enough. But it leaves out then those people that's not working for them.
Yeah.
So, so this is an area that we want to address and say, can we move forward with this? If we learned anything recently, where are we? And that's the purpose of the biannual meeting. Where are we? what do we need to focus on? What do we need to back off on? You know,
Yeah.
um, and the other thing, and not that our meetings aren't always focused on patients, because that's why we do what we do. But we really want to get more patients actually at the meeting, more patient-centered discussions.
Hmm.
So we're excited about that. So
Yeah.
that's why I said we will be calling you.
Yes, thank you, Professor Kaufman. And I think it is important to add that the meeting is not only for American surgeons, but
Oh, no, no, no. Yeah, yeah. The we work a lot. I'm a member of the ISVCA.
Mhm.
Many of the board members on the ASRT are also in the
Yeah. Mhm.
ISVCA. So, yes, we work often and well together. So, we will, we'll see, maybe we can make some of the sessions online. We're working on that to see if
Mhm.
people that are not at the meeting can at least watch, or, we'll work on
Mhm.
that.
Yeah, great. Yeah, thank you very much, Professor Kaufman. Thank you for support our initiative, patient initiative in this way, and I wish you only success in your work, and of course, all the best for your patients. And yeah, I hope to see you soon, and yeah, wish you all the
Okay.
best.
I'm looking forward to it.
Yeah. Yes.
Thank you again.
Yeah, thank you very much for your time, and I wish you nice weekend. And
Okay.
yeah, hope
All right.
yeah, have a nice
Thank
day.
you.
Yeah,
Bye-bye.
yeah, take care.